Thank you very much, everybody, for joining. Today is 3rd June, and our agenda is simple one topic: mucormycosis and COVID-19, because there is so much of controversy. We have Dr. Aditya Moorthy, who will start as a speaker, and then Dr. Sahoo will take over as a moderator. And when Dr. Sahoo is moderating, we have some interesting data from Shalby Hospital, which Dr. Bhavesh, Parekh, and Dr. Sanjay Gandhi will be talking about. Next slide, please. So I just mentioned that these are our esteemed faculty next, and along with them next, while Amish and I are coordinating the program, we have Dr. Sumit Mrig, ENT surgeon from New Delhi, and Dr. Rajiv Vijay Kumar. Hopefully he will join soon. He's a medical oncologist from Bangalore, and I thank him for connecting us to Dr. Aditya Moorthy. Then we have Dr. Govind, who is a hemato-oncologist also from Bangalore. Dr. Prashant Reddy, ENT specialist from Bangalore. And as we have heard, they are in the midst of a very big wave. Then we have Dr. Gyanendra Mishra, who is a maxillofacial surgeon from Ahmedabad. And Dr. Pawan Kumar Biras, who is a pulmonologist from Mumbai. Next slide. So with these introductory remarks, over to Dr. Aditya Moorthy as we move to his slides. Dr. Aditya, please.
Lots of people who are my close friends. Sumit Saab is here, Govind's here. Nice. Thank you so much for this opportunity, Dr. Parekh. It's a nice, varied, and a very august faculty. So since we are not into a kind of a mutual admiration society, we want to get on with the job. Let's see what we have going on here. I'm sure a lot of us around here are in exactly the same boat as I am, and all of us pretty much have a similar sticky situations right now. The point we are going to try and make is, I'll give a very brief introduction. That's been my remit about mucormycosis, and there's an august body of panelists who will take it from there, and I'll join them after this one. At the outset, there has been a fair bit of talk about mucor hitting us in the second wave. And where was mucor before this? Point number one, to anybody who may not be aware, I'm just preaching to the choir here. Mucor pre-existed COVID and will continue after COVID goes away. It was an exceptionally rare disease, and we would see a handful in our careers, and we had learned both to dread and fear the disease. Why in the second wave only? Actually, no. We saw a fair few of them in the first wave, and we even published about it. And it was at that point what I thought was a big series, and we published 18 of them. We are closing in on 10 times that number, and the end is yet to be in sight. And I have colleagues across the country who've done more. So we'll very quickly go through what I have gleaned of these things. And since I'm a maxillofacial surgeon, I will defer to my ENT colleagues to give their expert opinion on the ENT part of it. Before that, I want to clarify that this work is happening as a part of an immensely committed, driven team with many specialists. And this is not a one-man job. So with that brief introduction, I'll move on. I'm unable to control the slide. I'm assuming somebody. Thank you. So a very brief introduction to mucor. It's uncommon to the point of rare, and it's opportunistic, as in only in immunocompromised patients, post-transplant, patients undergoing chemotherapy, uncontrolled diabetes mellitus, so on and so forth. And this is the kind of presentation we used to have. And once COVID hit, COVID's teaching us in no uncertain terms that it has a significant impact on the innate immunity. Next, please. Just like preaching for the choir again, the types of mucormycosis. Very interestingly, one of my pulmonology colleagues, I'm sure our pulmonologist here will have a lot to say about it, is wondering whether we have a far higher incidence of pulmonary mucor, and it's getting drowned in the COVID features and the other infections that might have happened in the ICU. This is something very interesting. But right now, Rhino cerebral orbital mucormycosis is this devastating condition, and we have cutaneous extensions, very rarely primary cutaneous ones, disseminated mucormycosis, and primary cerebral mucormycosis with absolutely no sinonasal or oral manifestations. Next slide, please. So the point about Rhino or cerebral orbital mucosis is its mortality is extremely high, morbidity is extremely high, and it's exceptionally unforgiving. It doesn't give us time. Even when we do our best with the best of medications, we have anywhere between 30 to 40% of mortality when the brain's not involved, and higher when the brain is. It is our misfortune that we were hit so badly and so hard with mucormycosis across the country that we couldn't even muster the medication we needed to deal with it. I doubt that any country could have dealt with it where there's a 500-fold increase in demand for the medication. So we are fighting an uphill battle here. And next, please. So diagnostic challenges here. I will try to distill what little we have gleaned of it this time. The histopathology certainly is definitive, and the histopathology in the best of hands takes a couple of days, probably 3 or 4. And the turnaround time is not a luxury we have. Fungal culture, same story, a week. So we cannot assume Mucor and treat all these patients with the appropriate antifungal medication. We'll speak more of that in a minute. So at this point, what we are doing is we are using KOH mounts. We started this last year as a go-between for diagnosis. And while there are several microbiologists who have been significantly concerned regarding putting their money where their mouth is, as far as calling it Mucor on a KOH, there's been enough said about how they can only describe an organism. Several of them have understood the need of the hour and are commenting reasonably definitively on whether or not it would be Mucor. Why is that so important? What if it's bacterial? My ENT colleagues tell me most of bacterial sinusitis is managed initially conservatively. Conservative management, it's not time we don't have time for conservative management here, and we need to know if it's fungal. So what if it's fungal? Apparently fungal sinusitis is exceptionally common. Aspergillus mycetomas are apparently common. So we need to know whether it's Mucor or not to set on this job with the aggression we need here. Second point, what are we going to do when we operate? If it is just a very functional endoscopic surgery, as my ENT colleagues call this really delicate operations they do on the sinuses, retaining everything they can. This is not that. We are pretty much going in like a bull in a china shop. We are going to have to remove pretty much every disease structure. And we are not justified in doing so unless we have some kind of a diagnostic direction. And hence, when we have this potassium hydroxide mount, I unfortunately, by force of habit now, have begun to recognize broad aseptate right-angled branching hyphae and looking at Mucor as readily as any microbiologist does. And we can pull out a diagnosis of Mucor quite easily now as far as treatment planning is concerned. In a few weeks, hopefully, we should be able to tell you what kind of positive pickup rate has been in KOH preparations to diagnose Mucor. I can assure you that anecdotally, it's been very high. This has been borne out by later histopathologies, and only in a couple of occasions where we've operated for Mucor, we've had to change the antifungals to something lesser for aspergillosis. This brings us to the dilemmas we face. What if it's clinically mucormycosis? This is a disease which kills, but it's not borne out. The biggest challenge is faced by our ophthalmology colleagues, where you have an ophthalmoplegic eye with diminishing vision, but we are unable to tell them whether it's Mucor at all. If the radiologists are pretty sure, and the vision's continuously diminishing, there are some, for want of a new word, I say brave, with no sarcasm, brave oculoplastic surgeons who have chosen to stick their necks out and remove the globe to save an eye. And I cannot congratulate them more, because it is more than something I could do. Because we've had patients for whom we've sat on the exenteration for a bit of time, and we have ended up having cerebral spread and mortality. But these are all ethically, morally, spiritually confounding situations. And I do wish we never have to go through these things again. Next, please. Right. occasionally a little bit of frustration gets through after seeing this for weeks on end. Do forgive me for that. Pharmacotherapy challenges. It had never been a situation where there was any doubt regarding the drug of choice. Amphotericin B is the drug of choice, and liposomal amphotericin B has been the safest drug for a long time. While deoxycholate and lipid suspensions have been available, conventional deoxycholate amphotericin B was more easily available till this hit, and now we are searching for that as well. But these are going to be the mainstays of treatment. If we do not get lipophilized amphotericin B, I think we should stick to the other versions, even at the risk of nephrotoxicity. We can deal with the patient with no kidneys, but it's pointless if the patient isn't there to have no kidneys. Azoles are the newer drugs, and Govinda and I have had several discussions about the utility of azoles. In spite of how promising isoconazole is, there are still, it's a relatively new drug launched in 2015, and there isn't much literature to go back on. But beggars can't be choosers, and if we feel it's superior to posaconazole, that should be the next best drug. Posaconazole, however, has been tried and tested and has actually been a maintenance drug following amphotericin. So what tends to happen is if we run out of amphotericin, like we unfortunately do nowadays, the patient goes on to posaconazole. If we have isoconazole, we use that. Several times, a few of the patients have started posaconazole as primary treatment, and this isn't ideal, especially if we do not have the sustained release gastro-resistant tablets, because the absorption of posaconazole from the gut is exceptionally poor. But the gastro-resistant molecule has been developed to deal with exactly this problem. But this is not something that's offered by the suspension. So even in choosing posaconazole, we have to choose the appropriate medication. The posology has to be right. The route of administration has to be right. Echinocandins have no definite use here. It's of little or no value in management. There has been some reason why, I don't know why, but there have been some instances where caspofungin has been used extensively by some well-meaning but rather ignorant physicians, I'm afraid to say, because it gives you hope when there is none. Caspofungin has been investigated only in a very limited setting, especially compared to amphotericin as a dual therapy with amphotericin. That study itself has more holes than Swiss cheese. So I do not think echinocandins have any role. As a Hail Mary, dual therapy can be attempted, and people are having to fall back on itraconazole. Which only shows the desperation of the times we are in. Next, please. There are several medical issues. We have crystallized now into a Mucor team here. Just to let you know that the MaxFact team, we are 9 members, and pretty much all of us are on either the Mucor ward, the Mucor OPD, or the Mucor OT on a daily basis. It's 41 days and running. The nephrotoxicity has to be dealt with. We have to have a very committed nephrologist with us. We need to have physicians, or at least we need to get the expertise to deal with the persistent hypokalemia. Most of the patients come in with ketoacidosis. Post-op glycemic control is a terrible challenge. Secondary and resistant bacterial infection is something we see, and it adds to the complication. And neurological complications with mild cerebritis, confluent infections into the brain, all of these are some things we need to look for, especially when we have the patient with us for 15-20 days, however long it takes us to keep going with the amphotericin. Next, please. So this is the team we have, and this generally makes a very good team. There is some talk about who leads the team. It's just that no one does. We all have our slotted roles, but for the ease of understanding, we have to understand most of these patients go to ENT surgeons. I tend to be very unpopular among my colleagues when I say that ENT are the people who are best placed to deal with it primarily. The diagnosis is made by diagnostic nasal endoscopy and a KOH preparation, generally a tissue taken, which most ENT surgeons are very adept at doing. Ophthalmology is, from the prognostic point of view, the ophthalmologist is vital, And if that ophthalmologist has oculoplastic experience, perhaps they fit into the team when exentrations are needed. In ours, we join our ophthalmologist to do our exentrations ourselves. Maxillofacial surgeons have special interest and expertise in dealing with the structures, especially the solid structures of the oromaxillofacial region. Neurosurgeons are exceptionally important because they have to come in sometimes rather early rather than later to deal with the complications. We need to have a full anesthesia team ready to take on cases which, by and large, they would have pushed for the next day, or perhaps said they were unfit for surgery. All of these things change in a pandemic, and we are in the midst of an epidemic within a pandemic, and all rules are out to the air. We need to just stick to as much of basic science as possible, and yet not be terribly dogmatic about how we are going about it. A lot of patients need intensive care, physicians, and trust me, the sheer number of psychiatric referrals I've made in the last 6 weeks, I haven't made in the last 6 years. And this is not only for the patients. Next, please. So how do these patients present? There are some very subtle presentations. The chap on the right had isolated frontal sinus mucormycosis, and you can see mild ptosis on the right-hand side. Whereas the chap on the left, this is a post-op picture, but he looked pretty similar before we got to him. And significant ptosis and proptosis with ophthalmoplegia. Sometimes they present with nothing less than slightly stuffy nose, mild pain behind the eye, paresthesia of the cheek, very vague symptoms. But the more classic mucormycosis, next please, turn up this way. You have a dusky palate, you have an ulcer on the palate growing into a big necrotic area. Several times you can see the separation between the sea and the horizon here. You can see the well-perfused posterior part of the hard palate in the middle picture, and the duskiness with a droplet of pus in the palate there. All of this is indicative of fungal osteomyelitis and avascular necrosis of the maxilla. There is initial osteomyelitis and avascular necrosis, but sometimes it is just mummified and ends up with necrosis anyway. Next, please. Maxillary and retromaxillary disease are harbingers of death here. Retromaxillary disease through the pterygopalatine fossa, retromaxillary disease higher up into the orbit, and sphenoethmoidal disease can be pretty dangerous, and these actually form the indicators which point towards a poorer prognosis in our patients. Purely maxillary disease or palatal disease, the patients generally tend to do well. Next, please. The alveolus involvement is sometimes in more indolent disease, the primary presentation of the patient. However, what we see nowadays is that patients come in quite early, they are treated, they survive, and there eventually is going to be necrosis of the descending palatine artery bilaterally, which ever so slowly dies because of the invasion of the fungus, and we have late avascular necrosis. This generally tends to, these people tend to do quite all right. Next, please. The base of skull. I bring up this topic to state one thing. The base of skull is almost invariably involved at the level of the basis sphenoid. The point here is that the base of the skull remains dark gray, looks unhealthy, doesn't look like good bone for a long, long time. And this is something we have to accept. We are not going to remove the anterior skull base or the middle cranial fossa just because the bone looks unhealthy. There is something we'll have to just let go and allow the drugs or nature and the innate immunity to take care of. The only good thing about this is that if the patient in the first 3 to 4 weeks doesn't develop cerebral complications, chances are that he's going to live with it without too much of a problem. Can I have the next slide, please? The orbit, primary involvement on orbit is not a great sign as far as the prognosis is concerned, and more importantly, as far as the prognosis of the globe is concerned. Vision, well, loss of vision itself is a disaster, but the whole concept of an exenteration is something so abhorrent both to the surgeon and the patient that it takes some amount of acceptance by both. But unfortunately, we've become a bit of experts in telling the patients that the eye has to go. And surprisingly enough, my patients are more concerned about what happens to their teeth rather than what happens to the eye. I found it very funny initially, but then I later on understood that they are the ones who are going to survive, and with a sunken in face, when half the upper jaw is removed, they know exactly where their priorities lie. But both of them are exceptionally important, and even at the outset, we need to tell them that there is going to be reconstruction. While reconstruction is something that's going to be done a lot later, that part of the counseling conversation is vital. Can I have the next one, please? Right. Um, Not being of an ENT background, I will very quickly touch upon what my ENT colleagues do, and Dr. Sumit and other ENT surgeons here might tell us more about it. They do not perform any functional surgery here. They do extensive endoscopic debridement, and wherever, and there is, it's not that if they see doubtful mucosa, they may say, okay, let's give it a chance. You are not giving it a chance, because this fungus doesn't give it a chance. They're quite aggressive. They are not terribly bothered about leaving functional pseudostratified ciliated columnar epithelium there. They take it right out. I think that's vital. If in doubt, you take it out. And that probably changes the way we have to look at it, because with an endoscope, they can get to places you can't get to otherwise. And more importantly, what tends to happen after sinus surgery is that they go back for endoscope assisted washes. They look for debris, perhaps small fungal colonies, and if needed, they take the patient back to OT several times with us. Next, please. From our point of view, most of these operations involve removal of the upper jaw. These pictures are gory, but unfortunately the disease is as well, so I can't make it any prettier. The first one shows you, the top one on the left shows you a blackened anterior wall of the maxilla. That's mucor sitting right there. And the one on the right shows you an absolute white. It looks like the maxilla you would see in a skull, which is from an anatomy class. It's blanched white, and you can see that I have made a cut through the palate, through the dead bone. The rest of the dead bone I would be nibbling away later on. It doesn't bleed whatsoever. It is mummified for all practical purposes. But what we've learned to do is keep the mucosa, if the mucosa isn't entirely gone, and put it back where it was, kind of forming a soft tissue palate, so that the patient can have the Ryle's tube removed as soon as possible. Next, please. The same story, extremely necrotic maxilla. You just need to raise the mucosal flap and it pretty much pops off into your hand. Next, please. And I'm not sure if we have oculoplastic surgeons. I have left this slide on. If somebody is going to speak about it, great. Exenterations, we perform what we call lid sparing exenterations. The lid tissue is going to eventually collapse into the globe, and we place a prosthesis. I do not leave any periosteum back there, because it is the disease which spreads through the posterior ethmoidal air cells is generally lurking beneath the periosteum. Naturally, it has to spread through the periosteum. Leaving any medial, inferior, or superior periosteum is just asking for trouble. And now there's hardly a point leaving the lateral periosteum. So we do a very aggressive subperiosteal exentration, and eventually this patient will have a prosthesis. Sometimes we would have removed the floor of the orbit, the medial wall of the orbit, a little bit of the roof. So we'll have to search for answers on how to reconstruct. Other than a very basic spectacle prosthesis, we can think of a more complex implant bone prosthesis. Next, please. Right, at the end of it, we like it or not, we are going to have survivors, and we have to answer to them. The way we are going, we are managing to probably beat the so far published international count of 35% mortality. We may end up having close to 30%, 28 to 30% mortality in our series, and we'll also have 70% plus people coming back to us. And how do you rehabilitate them? Next, please. Now, there are two ways. You either do a microvascular flap, which Gyan is an expert at, but these patients generally are pretty done. I'm not very sure how many of them would tolerate another 10 to 12 days in a hospital, the expense, the pain. The easier way to do this is use 3D printing, use a good vendor, some skills, plan these dental implants which pop into the zygomatic bone. There are some very clever implantologists around. And next, please. And there you are. These are the implants sticking out of the patient's zygoma, operated entirely transorally. And this very sweet man is a retired commissioner of commercial tax, retired. He's of no use to me. And he's quite happy to get on with his life. He's another gentleman who had a basis sphenoid disease, which stays right there. He's perfectly fine. Next, please. Another similar story, a nasty mucor involving the palate with avascular necrosis, similar planning done and similar implants planned. Next, please. And there you go. We have a nice bar attachment. We've got some very clever dentists who plan these prosthetics. And next, please. There you are. And we have dentures in place. So it's not the end of the world for them. There are many ways to deal with this, but right now we are grappling with, we are in the midst of an absolute disaster. And I'm quite looking forward to hearing our panelists and their opinions. And thank you, Dr. Parekh. Thank you, Dr. Rajiv, for this time you've given me. Thanks.
Thank you, Dr. Aditya Moorthy. People in the chat are already appreciating the immense work and experience that you have. And I'm sure that they will benefit by contacting you in case they need to do so for a particular patient. We now move on to the panel discussion moderated by none other than Dr. T P Sahoo, who's a senior medical oncologist from Bhopal. Sahoo, over to you.
Yes, sir. Thank you, sir. It was really, I was enchanted hearing the talk. Such lovely work, and congratulations, Dr. Aditya. Next slide, please. Yeah, so I have the panelists. We have two ENT persons, Dr. Sumit from Delhi, and we have Dr. Prashant from Bangalore. It's a Bangalore loaded panel. So we have Dr. Gyanendra, maxillofacial, apart from Dr. Aditya. Dr. Gyanendra is from Ahmedabad. We have the pulmonologist, Dr. Pawan from Mumbai, and Dr. Rajiv, a medical oncologist colleague, and Dr. Govind, who is a hematologist and a transplanter. And we also have Dr. Sanjay Gandhi, who is also will be contributing with his pathology and the microbiology inputs. So it's a panel which I could not have asked for more. Probably I'm the only least qualified person to do this panel. That with that starters, I will that disclaimer. Let's move on. And thanks to Dr. Parekh for sharing this survey data. And Parekh sir can add anything more on this survey which people have to ask. But this was a survey which was done approximately 10 to 12 days back, I hope. And this was a survey where all the doctors who participated were allopathic doctors. Next slide, please. Yeah, so this could be the different possible presentations. We'll not skip into this because already we have seen a lot of these from Dr. Aditya's presentation. Next slide. Yeah, so it's a very common thing. We have heard so much into the media. I would ask with a very very simple question, and probably Dr. Sumit can take it first. What percentage of the COVID patients would ultimately go into mucor? Because I feel the way things have done, and we as medical oncologists have felt that our patients who also struggled with the other patients for mucor to get the ampho, they could not, and we had to deal with a lot more toxic than the conventional ampho. So it's a very simple thing. What do you think would be the percentage in India? We know India contributes to maximum number of patients with mucor in the world data series. So what could be it?
Thank you, Dr. Sahoo, and thank you, Dr. Parekh, for this opportunity. And let me congratulate first Dr. Aditya Moorthy. He has shown a very positive side with the maxillofacial work, and I'm sure most of these debilitating surgeries we have been performing, they have a far brighter side to look up with all these beautiful implants which their fellow colleagues are doing. So we at Max Saket, I'm heading the department there. I have the whole team at Max Saket has seen about close to 75 to 100 cases in the last about 2.5 weeks. And I think Bangalore is just a little behind us. So we have seen a little dip in the number of mucormycosis cases. Now, I have personally operated about close to 34 surgeries in the last 7 to 10 days. And in fact, we have collected data from 4 parts of India, north, south, east, and west, and Dr. Aditya was a part of it, where we framed the guidelines for Indian Academy of Otolaryngology and Head and Neck Surgery. And so far, I can tell you that I have seen 100% association of mucormycosis with COVID in this way. It is
Okay,
not.
my question was, if you have 100 cases of COVID, how many would have mucormycosis? I would put it the other way around.
So if you are putting that way, then
Yeah.
probably you can say that Delhi has seen about 1100 cases till now, in the state. And if I count the number of cases of COVID, so maybe you can say about close to 1 to 2%, not more than that. But since the number of COVID infections have been unaccountable, it has been
that's why
we would not be able to pinpoint that how many percentage got converted. But one thing I can tell you, all of them who came with mucormycosis for all COVID recovered.
That's fine. Definitely. So we would get COVID mucormycosis with non-COVID patients also in hemat and the renal transplant and others immunosuppressed patient. But I think the data, what you tell, next slide, please. The data, what has been published in the literature, even from the Indian literature, has been around 0.2 to 0.4% of the patients of COVID would probably get a mucormycosis. That's the data, not even touching the 1%, because we saw such a huge second wave and the numbers were so very high. That's why the absolute numbers were high. On a percentage, it would be less than 0.4, and that is what the literature points out. And here I look at this data, and this data looks very nice from the survey which was conducted. And I feel here you see that at least 1 in every 2 professional who dealt with COVID had seen a mucormycosis. So this is something also I take it, but yes, on the percentage basis, it is around 0.2 to 0.4. Next slide, please. Okay, this was something of the person in mucormycosis. I'll just not put a lot of importance to this slide set. Next slide, please. Yeah, so this is something very important which the data captured, and I will go to the other ENT colleague guy here and then go to maxillofacial. Prashant, Dr. Prashant, can I tell you this data from whatever the responders were, they would not be ENT guys. I understand for medical oncologists like me, it would look the same all around when the CT scan sees the involvement all around. But would you point to a particular sinus which the COVID really attacks? It's a maxilla or it's a ethmoid, or what do you think would be the most common thing?
So if I may take that question, so it's not actually the sinus which is actually getting affected. It's the middle turbinate, which is a part of the ethmoidal sinus. That's the most common part which is getting affected. The reason behind that is the middle turbinate has the end arteries, and also it's the most anterior-most part. So before entering any kind of a sinus, the spores and also the end arteries are the major reason why it has the highest chance of getting ischemic. So that's so whatever data you would have pulled out, I think since middle turbinate practically comes because into the ethmoid, so it would be the ethmoidal sinus. But if we look at just the sinuses, excluding the middle turbinate, then yes, definitely the maxillary sinus is something which I very commonly see. In fact, today also I operated 2 cases which are similar to maxillary sinusitis.
Agreed. So that's basically I wanted to point out on this part of it that because of middle turbinate, ethmoid is the most common thing that we normally see involved. Next slide, please. And that was also put up in a paper from Jaipur. And this paper from Jaipur presented the small data, which was in the initial part of this year in the Mucomicrosis series. There are 23 patient data, and they found ethmoid to be involved in nearly 100% of cases, which I found was very strikingly. This could be because of the responders who would not have picked up really interpreted the CT scan rightly, because I don't feel that data can be that wrong. The maxilla was the second most, as you rightly pointed out. So Dr. Gyanendra, if I look into this and look into the orbital part and looking at how you have seen your cases, would you tell me that in every, let's say, case, I think this mucomicrosis has been a rhino cerebral predominantly. That's what we have seen, very rarely of a pulmonary. Point number 1. Point number 2, how many of your patients with the mucomicrosis coming to you have an orbital involvement?
I guess not a lot, of good percent. I treated close to around 25-30 cases, of which I've seen around 5 to 7 with orbital involvement. Surprisingly, patients coming to me, a lot of patients were already very aware and say skeptical about if it is there or it is not there. And a lot of patients we have treated early.
Okay. So basically, from your series, you tell them 15 to 20% have orbital involvement, and you attribute could be lower because
yes,
so because they were much more aware population group and they came to you early. Dr. Aditya, your series, you feel how much was the orbital involvement coexistent with the sinus involvement?
Right. The last year's paper is there to be seen, but this year I can give you absolute numbers.
It's approximate.
I can give you the numbers. I haven't done the percentage. I promised to do so to Dr. Parekh, but I didn't.
So out of 180 patients which you told, what would be the orbital involvement?
179 surgeries as of yesterday, and orbital involvement has been about say 46 or 42, and exenterations have been 19.
So that's fine. So we are coming to the 20%. So probably this was the earlier part of Mucor, which the paper came from Jaipur, and people were learning how to deal with it, the big mess, and that's why the paper puts at 40-45. But the coming to is 20%. That's for getting it. Now coming to my pulmonologist, Dr. Pavan, which factor would you attribute? Because this is something very important. I will also come to you on how different is mucomicrosis present on an immunocompetent and an immunosuppressed? This is something which I feel the intricacies no one can better tell than you, Dr. Pavan. First, let's come to immunocompetent versus immunosuppressed. Do the mucomicrosis presentation, is it different? And that's we start off, and then we go to the next part.
See, most of the cases so far we have seen, I practice at Tata Memorial Hospital, we have seen in most of them as hemat-onc cases. The other center we see in the transplant cases, but it has been so far majoritarily seen in the immunocompromised individuals only. The presentations, if you ask as a pulmonologist, the literature says all cases among the mucormycosis around lung involvement is from 20 to 24% cases. Most of them is Rhino orbital presentation only, most of the times. And we get involved because somehow the sputum shows a mucor. It might be just aspirated from this sinuses versus a lung to start showing some opacities on the CT scan. So I do not find major difference in the presentation in immunocompetent and immunocompromised, because all those majority of signs have been described in immunocompromised only.
Okay, let's hold on there and find if any other panelist has something to say. So there is a beautiful paper which has come in the consensus guideline in 2019 for mucormycosis in Lancet publication, and there is something they have written about the differential presentation. That anyone in the panel wants to come up and volunteer for this question?
Dr. Sahoo, I would just like to comment on in our onco patients. Since in the past, like, so we've treated so many leukemias and lymphomas. We've hardly come across, I can probably count and say I've had like 5 cases till date over the last 8 years where we've seen mucormycosis. But then it's been a flurry right now.
Yeah, I understand. So the point I was making is the immunocompetent patients, mainly their presentation is in the skin and the soft tissue and the cutaneous part of it. Majorly they happen because of accidents or some other trauma form where the skin is lost or some burn after a burn. In immunocompromised, we see majorly the hemato-oncology, which you really presented for, you look for. Pulmonary is one of the sites. For diabetes, typically if you look at it, it's mainly Rhino Cerebral. And we will keep this thought because I feel this has a very important thing to play, how the presentation has been with COVID this time. With that background of immunocompetent and immunosuppressed, where the presentation could be, because they're clearly written in the papers across, especially the society guidelines, international ones. So now with you being on the there, now would you tell me that with the patients you have seen, I don't think you would have seen a lot of the, have you seen how many patients you have seen for mucormycosis in this second wave?
I've seen around 3 patients right now in the second wave.
Okay, so for that, I will come to you when I come down to Dr. Sumit or someone who has seen a larger number of cases. Would you attribute that all your patients receive steroids? Let's now come down to risk factor. And have we blamed steroid enough? Or
no.
Among all the risk factor, which you feel is the most prominent risk factor, 1, 2, 3?
I think in the study which we have done, we have the data. We are actually collecting the data and still trying to make a lot of correlation between various confounding factors. That why we saw so much of mucor in this wave. I think the most important was all of them were having uncontrolled diabetes. All of them.
So you would put uncontrolled diabetes as the point number one. Number two?
Yes. That was 100% present in all the patients. Point number two, almost 90 to 95% had taken some form of steroid at home, unsupervised, supervised, and also in the hospital.
Can I ask you something here? This is very important because the steroids, as per recommendation, has been for 10 days for patients who are hypoxic, 5 to 10 days, and at a dose of 6 milligrams. So, Dr. Prashant, if you can also pitch in here, your series, and Dr. Sumit, you can also tell me, has your dose of your patients with mucor been on a higher side?
Yes.
And have they been of a longer duration? All of them?
So what I can tell you so far, what data we have seen, most of them have been on dexamethasone, and they have been started on 8 milligrams, but since the saturation started falling down, it was increased to 16 and sometimes 32 also.
Dexamethasone, that's what you're speaking of.
Dexamethasone. Apart from that, we have seen patients taking Medrol, methylprednisolone at home. There have been, the data also shows, but interestingly, the data which is very surprising revelation is that only 10% of these patients received some form of high flow oxygen or Solumedrol when they were admitted to the hospital. So not all of them were admitted, but all
received antibiotics. All of them had received antibiotics.
Yes, all of them received antibiotics. So important point is all of them received steroids, but all of them were not admitted. But all of them had uncontrolled diabetes, and majority of them, since they were taking at home, it was not supervised by a doctor, and the was around 400-500.
Point taken. Dr. Prashant, anything you want to differ on him? Then only you can come in and just tell what has been your series. Is it any different? Because the COVID and steroid where the controversy started from 6 milligram for 5 to 10 days. Where did the steroid really come in? Can you, Dr. Prashant, and then I want to go to Dr. Govind then. Yeah, please.
So my case series of how many ever I have operated is only 19. I don't have extensive operations under my belt. It's only 19 over past 2 weeks. And of these, I think only around 14 of them had taken steroids. And 5 of them didn't have hospitalization, and also they didn't take steroids at home. I specifically constantly asked them.
And antibiotics for all? Antibiotics for everyone?
So again, of 14 who had been hospitalized, they've had antibiotics, but who were at home isolation, they didn't have any kind of steroids, no antibiotics, nothing.
Dr. Govind,
one thing which is more which I feel as the major crucial factor is COVID itself. The microthrombotic effects, that is the main culprit than blaming any kind of medication. The microthrombotic effects, which leads to the ischemic changes in the anterior aspect of the middle turbinate, is the main culprit behind all these rise in cases.
We will discuss this when you come to the first wave versus second wave. Has the COVID changed in the second wave that it produced so much mucus? We'll hold your thoughts for that slide. So Dr. Govind, if I can come, we as hematologists and medical oncologists have been using steroids for ages now. We have seen mucomicrosis. Yes, all of us have seen. It has been 1, 2, 3, 4 cases maybe. We can count your fingertips. Dr. Govind, why is it that we use a longer dose of steroids, the higher dose of steroids? We never used to see mucor, and suddenly we see mucor with COVID. Or is it that because it is that our steroid use were majorly in the children pediatric age group, here we had to use steroid whatever, and these patients were already having COVID, that added to that, and diabetes was the most important thing.
Yeah, thank you so much. I hope I'm audible.
You are.
Thanks. Yeah, you're right. We hardly see mucor. I mean, among our fungal people, we put mucor at the lowest because the incidence of mucor is low. The sheer burden of the mucor load is not that high, except in the allogenic transplant sector. We don't routinely see it in the lymphomas and myelomas. Yes, we see them in leukemias, which are bad, which is. And even in that, Aspergillus and Candida are the bigger killers than Mucor is. But we always prophylax. And since we prophylax, we don't see enough Mucor because for the most part, most of our patients, either leukemics, MDS, or transplants.
What drug do you prophylax them?
So the most part, these are on posaconazole, which have
so you already
activity.
Okay. So you already are giving them a you already are giving the posaconazole. Okay.
That's right. So those on posaconazole with regular drug monitoring, which is actually a very important thing which is being missed, and they generally do well, and they don't develop secondary hepatotoxicity and other issues.
Next slide, please. Please continue.
What I have seen in a risk factor assessment for the patients with hematological malignancy plus COVID, most of them had Candida, which actually was brazenly being ignored in the face of Mucor. I think disseminated candidiasis and Candida risk score for all these patients were pretty high. Second, previous voriconazole use in our segment of patients predisposes. It kind of selects Mucor, Rhizopus oryzae, from the whole buildings of the dungeon. And the other two
antibiotics, does it predispose to Mucor?
In our hematological malignancies, what is data proven is previous voriconazole use. Antibiotics have not been consistently proven to at least spark off Mucor.
But for fungal they are, but not for specific Mucor.
Yes,
that's the point you want to make.
Yeah.
I take your part.
The other thing was acidosis. When we saw acidosis, when we saw ketosis, when we saw ketosis secondary to both hyperglycemia as well as sepsis, these were the patients with, which had an acidotic milieu, ferritins were high. The Mucor was able to use the iron there in the milieu, and so the transfusions we were giving, we're just priming the patients with more iron, and iron is necessary for these guys. So they use it as a chemosidrophore to kind of use in these ions. So they thrive. I personally didn't see a lot of Mucor in the last, in the first wave, definitely we didn't see much. But again, for obvious reasons. In the second wave, out of our two high-risk leukemics, one of them had Mucari, other had Fusarium, which was not outside the incidence of what we were seeing. And again, in the patient subset who were on chemotherapy, we kept deferring chemotherapy.
Hello. Yeah. So Dr. Pavan, you're there. So what I get it is diabetes, uncontrolled diabetes, and decay following diabetes. That is the major culprit, and it is a mixture of more than one. Is that right?
Yes. Sorry,
Dr. Pavan, we are breaking. Your voice is breaking.
Wi-Fi went off, and I kind of missed the.
Sorry, there is someone else speaking.
Dr. Pavan,
can you hear me now?
Yeah, please. So now to what I get from it is it's a mixture of all. 1 + 1 here comes to 4. That's what it is coming to. But majorly it is uncontrolled diabetes, and definitely all the papers are telling that you have very high incidence of decay. Around 40 to 50% patients have decay. Is that contributing apart from the hypoxic milieu, the iron overload, everything contributing?
I completely agree with the previous speaker. See, we have used steroids for ages. In interstitial lung disease, in hypersensitive pneumonitis, we give steroids for 9 months in a tapering dosage, but obvious. It's not only steroids, it's the steroids triggering the diabetic ketoacidosis in this patient, unsupervised use, and the COVID itself, the immune modulation which happens with COVID. All these three together cause this unholy trinity. And definitely they are making patients prone for mucomycosis. Definitely agree with the acidosis, the acidic milieu, which is utilized by mucor to grow. The iron, which is the hyperglycemia will cause a lot of iron unbinding from transferrin and ferritin. It will also alter the T cell and B cell response by hyperglycemia per se. The COVID will definitely lead to T cell, B cell deficiency or immune modulation.
Please go on the slide. And please continue.
So all these three definitely together causing this, not one single risk factor like steroids can be blamed, but yes, the complex interaction of these three definitely making patients to prone for COVID.
So this is what I really wanted to point out. It's a combination of factor, and uncontrolled diabetes and decay is probably the major player which has been. Steroid has probably contributed to the thing. The immunomodulation and the lymphopenia that's happening with COVID predominantly, that's also probably playing, and that's something which is very, very important for all of us to remember. There's a question from Dr. Amish. What is the reason for male predominance? There is a paper from Dr. Avdesh Kumar which has a male predominance. Any panelists want to take this till I go on the slide? Please go on continuing with the slide progressions, please. By till that point, any one of the panel who has an answer to this, please can answer that. Continue with the slide, please. Someone wants to take it? Why males are predisposed to mucor? Please go on. Please go on. I'll tell you when to stop the slide. Dr. Pawan, you want to take this because no one is volunteering. Do you know the answer? Because I do not know.
See, we need more data on this. It is,
Okay.
you know, these studies are happening in most of the tertiary care centers. We know the data from the community.
Yeah, stop it. So, Dr. Amish, if you can come in and tell, because I think the panel does not know why there's a male predominance.
Dr. Sahoo, can I add into this?
Yeah, please, Dr. Sumit.
So I had a discussion with the internal medicine regarding this, and it's a right data that even in our study, 80% of were males. So it is not something to do with the islets of Langerhans in the male and the female pattern, and it is not a proven data. We need some more studies, like Dr. Pawan is saying, but it had something to do with the sugar level controls and the insulin release in the body.
So basically, you're telling that there is something here happening in male that is affecting the islet of pancreas, which COVID is affecting person.
Yes.
Because
During
of that,
COVID, we have seen few patients during COVID infections getting pancreatitis, getting GI morbidity along with the COVID pneumonia. And there is a correlation. I cannot pinpoint a paper.
Even there is a correlation of the attack of the islet of pancreas because of the COVID. That's why hyperglycemia is happening. That's also there.
Yes. That is supposed to be an hypothesis.
Okay.
That is why, and it is very correctly you have said. Even we have seen in our study 80% predominant males getting mucomycosis.
Okay. So there is a wild thought where Dr. Rajiv can a deep painful nasal swab for the RT-PCR with the initial lesion. I'll just not discuss on this at this point. And when we end this panel, someone can take that question because this will go haywire otherwise. So what this paper from Indore, it is not published. They had 210 patients, a big data. I cannot vouch for authenticity. It was put up in the net. And this paper from 210, they have antibiotic used in 100%, steroid not used in 14%, nearly what is being depicted here. 21% were not diabetic, 36% were at home, oxygen only by 52. Zinc was not tested, and age group was more than 40 in majority. We'll go ahead, please. Go ahead, please. Yeah, this is the paper which I really wanted to point out from PGI Chandigarh. One of the first papers came out in December from the first COVID times, and this was that they reviewed mucomycosis with COVID, and that time they had 8 cases in the world. At that point, maybe Dr. Aditya's paper was not published as of then, and they found out that the mortality was really high, but there the patients used steroids in nearly all of them, and 3 out of 8 were without comorbidities, 5 or 8 were with comorbidities, and the PGI patients actually survived. Next. So this is what our survey showed, that no steroids are not applicable. I take it the steroids were not a factor. 50% of the respondents, Dr. Parekh sir, in the survey which was shown, did not attribute it to steroids. So do you think, sir, it is the erroneous data because it is way far from what we have seen of 10 to 15%?
No, Sahoo, clarity.
Yeah, please, Amish.
Yeah, Amish, before you start,
answers,
can I just clarify?
Sorry.
That not applicable is patients, doctors who have never seen mucormycosis. Patients.
Okay, sorry. So that is a confounding factor that could have pushed them.
That is what I wanted to say.
Okay, sorry, sir. Next, please. So for diabetes, again, this confounding factor taken together. So it is, but the papers which has a real data is pointing towards uncontrolled diabetes, and the incidence of decay is too high, around 40% or more. Next. This is again the HIV and allogenic, as Dr. Govind told in his series. Also at this point, second wave, we have seen 2 cases. That's what we'll take it, that it is not majorly seen in the allogenic transplants cases, and the hematological malignancy cases. I, in my practice, or others have not seen increase in the mucomicrosis. Next. Okay, so we will now bring in Dr. Sanjay. First, most important is, how do I go ahead? We take a biopsy, we take a CT scan. How important is the chaos staining? and how can we differentiate quickly in 15 to 30 seconds? Is the histology, because the way the hyphae looks, does all this make a difference? Because aspergillosis is the most common differential diagnosis.
Yeah, definitely. Histopathology is the gold standard as far as I concerned. KOH, definitely it is a quick answer. Within 10 to 15 minutes, we can say, yeah, there is a separate fungal hypha present or not. But for KOH, we have limited tissue. In histopathology, we have entire specimen. So we can proceed entirely and we can
Can
find
I ask for a clarification?
Yes.
Can we say histopathology is the gold standard, or should we say culture is the gold standard?
Culture is the gold standard, but it will take 7 to 14 days.
Agreed, but I think that remains the gold standard, at least for now.
Yeah. For rapid diagnosis, we should rely more on histopathology. Definitely.
Okay. Yes, and can you differentiate? Next slide, please. Can you tell us how do you differentiate aspergillus from a mucor? Next slide.
Yeah, mucormycosis is first is the mucormycosis picture. We can see broad, non-septate fungal hypha with irregular branches. The simple difference is aspergillus is septate, short.
Okay.
And mucormycosis, broad, non-septate hypha.
Okay, so basically, if I look at the picture on the left, those are the mucomicrosis.
Yes.
And this is what it is. The hyphae is very broad. It is around 10 to 15 microns.
Yeah.
And in asper, it is a very small, short hyphae.
Yeah.
It's around
septate.
2 to 5 microns. And these are septated, and this is not regularly septated or hyposeptated. That's asper. Yeah. And there is a dichomotor branching form in asper, which is irregular branching form in mucor. So is that what little bit of what we want to know? This is the major difference, how you differentiate between both of them.
Yes.
Okay. Yes. So, and what do you have to say about the galactomannan test and the D-glucan test? How would they? How should we do it? And if you do it, how does it help?
As a histopathologist, I do not recommend much galactomannan.
Okay. Next slide, please. This is the angio invasion. And once the angio invasion happens, happens in mucor. That was the panel told. And I want to tell that this photos were contributed by you, sir. That's what it is. Yeah. So thank you for allowing us to put it here. And the angio invasion really causes the thrombosis and the necrosis. That's what the characteristic of the mucor is. Next slide, please. And this actually paper tells you, and this is the recommendation, the guidelines, that if you do a galactomannan and the D-glucan, and if these are positive, probably you are looking at invasive other fungal infections, and that really excludes a lot of things. But histopathology, KOH stain, and as rightly pointed out, and the culture, and now also people do a lot of antibody testing. If that is available, that also could add on to the way how you diagnose mucomycosis. So is it a fair idea, doctor, to conclude that this is how you should diagnose?
Yeah.
Okay. Perfect. Next slide, please. Next slide, please. Yeah. So I would bring in Dr. Purvesh sir here, because I know that he was very passionate about it. Sir, do you still? Yeah,
Dr.
please. Anyway.
Can I just ask one question to Dr. Sanjay?
Yeah, please.
We have excellent mycologist at Max Saket, and like you said, we are getting results in about 25 to 30 minutes, as in soon we send them the KOH samples. Now, what my mycologist told me that if there is a true sample taken, the mucormycosis grows very fast on Cerebral dextrose medium, and within 24 to 48 hours, you start seeing wonderful black colonies. You might not see the complete florid growth, but you are able to pinpoint that this is mucor. Is that true? That
mucormycosis is rapidly growing. Rapidly growing. Definitely, it is true.
And one more important discussion we had with our mycologist. We had patients where we had mixed infection of aspergillosis with mucormycosis.
Yes,
I had one.
The KOH sample, which was sent intraoperatively, because the pre-op there was no sample during the nasal endoscopy. The intraop showed aspergillosis, but when we got the culture, it showed mucormycosis. So what explanation they gave me, that the colonies of mucormycosis grows very florid and sometimes predominates over the aspergillosis. So sometimes you may have a mixed infection. But this is important because the treatment modality is very different for mucor and asper.
Yes.
I will speak that on the treatment part. Is it really that different? Are the drugs different?
Yeah.
But Dr. Parekh sir, do you still believe that this could be one of the causes why we are more on the second wave?
So I was only raising this as a question.
Yeah, that's
I
agreed.
have,
So
I have
what
absolutely
are the...
no idea. I have absolutely no idea
Okay.
whether
Okay.
there is a difference between medical oxygen and industrial oxygen as to the amount of spores of mycobacteria, mucormycosis that they might have carried.
Or the purity which they have, the purity factor.
Yeah.
Okay. Anyone in the panel wants to say, because there was at least big... Yeah,
yes,
please.
Dr. Parekh.
Can I just bring out two events? See, one, we have extensively studied whether mucor grows in our humidifiers over many years of transplant. We keep doing a lot of cultures, surveillance. We haven't been able to prove in the worst of humidifiers and the distilled water that's poured into it that mucor germinates in water. We've never been able to prove. You can find Ralstonia, Burkholderia, a lot of Pseudomonas, guys, but I don't think there is any data that we've been able to find that it germinates in water. I don't think Dr. Arunalok's data also shows this at PGI. The other point I'd like to make about was the combination of Aspergillus and mucor. Very rightly, the previous speaker had spoken about how mucor kind of dominates the hyphal growth when in a culture, XY, but in the body, mucor actually doesn't do this. Whenever you see mucor, you can be almost 50-60% sure there is co-dwelling Aspergillus or Candida with this patient in a hematological malignancy for sure, or any patient in a critical care unit whose score for Candida is high. It would be nice. I know there is no empirical prophylaxis for mucor and fluconazole doesn't work, but think about fluconazole for the sake of the Candida and the tubes and the remaining things, because mucor may not be directly causing mortality. There might be a whole lot of other things there.
Yeah. So in my patient, which we lost, actually, there was a combination of Asper and a mucor, not a cancer patient. Dr. Bhavesh bhai, you wanted to make a point, please.
About the industrial oxygen, what my intensivist tells that when we use without water, like high flow meter or the oxygen, where they are supplying the oxygen, if they are not using, they are using dry oxygen, the chances of fungal infection is less when they use with water. So this is also one of the observations.
It's not a well-proven study, but there's an observation what they want to do.
Absolutely.
Okay.
Absolutely.
So next, please, we'll stop it here. There have been hypotheses, hypoxia and fungal infection. There are papers that the fungal infections are more in hypoxic conditions. Dr. Rajiv, you want to say on this? And then I will ask probably Dr. Prashant, because as a ENT specialist, what he feels of this, because mucor, we have that hypoxia already there. The ferritin, iron is already there. The milieu is well set for it to grow in a COVID patient. And second point which I want to say is, also there have been papers of hyperbaric oxygen which people have tried to treat mucor also. So with that, do you think hypoxia, which we saw in the second wave much more than in the first wave, would have also contributed to the other factors which we spoke? Dr. Rajiv.
It is possible that the hypoxia might have been a confounding factor or a contributing factor. You really can't say with conviction. These are just only probably theories. One important thing is that, like I had told, although it is a controversial statement, you're causing some amount of nasal epithelial damage. So then after it's probably, along with it, some microangiopathy due to COVID.
So you have started the process. You have started the process. That's what you told. Okay, that's okay. Point well taken. Dr. Prashant, anything on hypoxia and the fungal infections? And then Dr. Pawan, the last one. Yeah.
Yeah. So as I had already mentioned, that most probable cause is the microthrombotic effects of the COVID virus, which is causing the issue. And as we already know that the maximum amount of changes which are seen, or the most initial presentation of mucor or any kind of fungal. So I prefer not to call this a mucormycosis. I prefer to call it as a fungal sinusitis than mucormycosis, whatever is occurring right now. The whole reason behind it is we are seeing an intensive amount of mixed cultures. Of the 19 cases, 14 cases were purely fungal infections, which were purely mixed fungal infections.
Mixed fungal infection. Okay.
And Dr. also, I'm also at the same time seeing acute necrotizing sinusitis. It is not fungal sinusitis, it's acute necrotizing sinusitis, which is purely secondary to COVID. I have not got any fungal infection, not got any single fungus on the histopathology. this was pure bacterial or pure acute necrosis secondary to avascular necrosis. So this is something which I've seen, and this particular thing is something which I saw in a 19-year-old kid recently, last week when I operated. So it was, the bones were literally coming off in chunks.
Okay, Dr. Pawan, hypoxia.
So see, the chronic lung diseases, most of them are on high flow, on home oxygen therapy, humidified or non-humidified, but we have never seen a mucomycosis in them.
Yeah.
They were on steroids, but never had a mucomycosis, a single case. So definitely there are other factors which are dominating in such situation. Hypoxia can be one of them.
Why I'm bringing this, Dr. Pawan, is what happened in second wave, what didn't happen in first wave. Could it be the strain of the so-called the Indian strain of B16 1.617, or could it be the hypoxia which are much more there, or could be something, because there is something differentiating the first versus second. So can you point that also? Take that question also.
So the patients with severe lung disease with COVID-19 we had earlier also. So definitely something has changed in the second wave. Either it is the load of the cases, the severity of the illness, presenting late in the hospital, taking treatment unsupervised at home. And again, the diabetes factor comes in, steroids comes in. So there is definitely other, hypoxia might be a contributory factor, providing an acidic medium for growth of a fungus, but there are other factors which must be dominating the picture other than hypoxia.
Okay.
Dr.
So
Sahoo,
basically,
Dr. Sahoo, can I come in with a very quick point
Dr.
here?
Aditya, please.
Yes. One very quick thing is the title of my paper was suggesting that COVID, uncontrolled diabetes, to qualify uncontrolled diabetes, and corticosteroid abuse was an unholy trinity. Apparently, the term has caught on quite a bit, probably because it means so much. I do not see how at a quick perusal of our data, now it's a significant number, it's about close to 180, that it changes a lot. Of course, there are going to be outliers to the normal bell curve here when you look at the Gaussian distribution here. There are going to be some patients who are not on steroids, like it would happen even before COVID, and there are some patients who are going to be non-diabetics. Most importantly, we have to accept that we do not have a grip on the COVID numbers this time at all.
So because the absolute numbers were more, you saw more cases. So that's
absolutely. If it is a proportional linear rise, then we are just looking for answers where there aren't any questions. So we have to accept this politically incorrect fact that we just do not have a grip on numbers. If everything has gone up by 8 to 10%, why shouldn't the incidence of mucormycosis have gone up by 8 to 10%? Thank you. Sorry for interrupting.
So no, that's okay. So, and that's a vital point. What you are pointing out, although other factors could have contributed, we can hypothesize till we reach to a conclusion. But you are telling the numbers this time are more because the absolute numbers of the denominator was too high. So the numerator had to be something more than what you saw in the last wave. And there was a question which was put up: can frozen section be used for rapid diagnosis? It was told yes by Dr. Sanjay Gandhi, who's the expert here as a pathologist. My only point is, can we be sure in a frozen? And are we really, to my surgeons here, can I ask Dr. Gyanendra Mishra here, because he has been not involved for quite some time now. Dr. Gyanendra, sir, do you feel you need a frozen section at all? Let's come down to the first basic set. And why do I need a frozen? I would be looking at the CT scan. I'd be looking at how the things have looked. If I have a blackish discoloration already classical, which was shown in the previous presentation, I'll be anyway debriding it for my tissues to be sent it for further testing. Do you need a frozen? If yes, what is the situation we need a frozen?
So personally, I don't think we've needed frozen so much, because based on the background of clinical history, CT examination, as you rightly said, and QH examination, which is pretty faster, probably equivalent, it takes equivalent time than frozen section. And the microbiologists are more sure about QH mount, and I did not find many people who were more confident about frozen section. So I don't really feel the need of a frozen section with this.
Okay, so answer is very clear. Do we need frozen section? The answer is probably no. Can we diagnose it? Probably yes, but still the gold standards remain as the histopathology and the culture, and if the gene typing can be done, we're perfectly fine with that. So we move on to please move.
One point.
Bhavesh bhai.
Your major point is that what is the difference between first wave and second wave?
Next slide, please.
That in advanced use of steroid, I think in the second wave, before that is in March and April, in January and February, most of the COVID cases has been treated by the general practitioner, and inadvertent use of the steroid or home use of steroid is also one of the biggest factor of the mucormycosis also.
We use higher doses and a longer duration. That's what the point is.
General practitioner also now started COVID treatment. That is in the month of November, December, or December, January. That was not in the first wave.
So indiscriminate use of steroid will be appropriate.
As well as antibiotic.
Okay. Yeah, please. Someone wants to come. Yeah, please.
Can I ask a question? Can I make a comment? Can I ask a question?
First, Hemant Malhotra, sir. I just have to take him whenever he's there.
Yeah, sir. So I think it is something more than steroids. We are used to giving steroids big doses like 1.5 milligrams per kg, 1 month at a stretch. Patients have hyperglycemia. They have immunocompromise. All those things are common, but we don't see mucor so much. So I actually, I don't know. We have to discuss.
Sir, what do you think are the 1, 2, 3 factors? Is it that the decay uncontrolled and the ketoacidosis that happened, the acidosis that happened was spoken about, are the main factors, and the COVID per se was making the immunomodulation and lymphopenia that was associated with it?
I also think so that there is some direct mucosal injury or impact by the virus, and also maybe some particular subsets of T cells are specifically depressed by the virus.
Okay.
All of us are using, reusing masks. So what about mucor sitting there in the mask and then infecting us? And somebody posted on the group that it is because of the injury produced by the nasal swabs, which we do. It's probably multifactorial, but I can't put my finger on why we have so many patients.
So definitely that's the point. It is no definite answer is there, but we have lot of factors which could be contributing. But the major thing that has come out of discussion after this, we are going to go to treatment part and then close the thing, is that the diabetes is uncontrolled sugar is the appropriate word which I'll use it. The COVID infection per se, and these could be, and steroids have been indiscriminately used. This could be contributing to the factor, and there is something in the second wave which was put up maybe because of the denominator which was too high, but there could be something else. Maybe the strain could be responsible for it, because I would have thought of the denominator factor. I thought for it that also, but UK never documented when they had a large second wave. So we have something more than that. And there's a question from Dr. Rajkumar, and the question is, what percentage develop mucomicrosis? We told about it that it is 0.4%. What the data is, some people have felt it is 0.2 to 0.4. It is not beyond that. That means for every 1,000 COVID patients, you will get 1 to 4 mucomicrosis. That's what we discussed in the previous part. Okay, next slide, please. So this is what has been in the in our survey, that the second wave people have dealt with mucor more commonly. Next. And there is a comment as we are telling the second wave variant is causing more microangiopathic thrombosis. This is a discussion which had in the Bhopal group, that we are looking at more of a vasculitis type of thing. We are looking at a lot of ischemias in the abdomen. I had one case which I operated 1 week back. My gastro colleagues, surgeons have had a lot more cases. So that is also playing that there are a lot more vascular events, and that could be a point also. And that could be hypoxia. That's why I brought the hypoxia part in. So now coming to treatment, I want to bring in Dr. Gyanendra and then Dr. Prashant and Dr. Sumit in that order. Surgery and its extent. First, let's go to, let's say, there are 2 different parts. I have a sinonasal, I have a pulmonary. There are 2 things which I'm looking at. And the abdominal. 3 parts where surgeries can be done. Cutaneous, I expect easier surgeries because it is easily done and it is on the external part. So do you feel surgery is important? All the answer is yes. What is the extent of surgery? Should it be just debridement to remove the necrotic tissue, or should it be beyond that, that the vascular tissues should be there, or you just would do something in between because the antifungals are going to take care of? Dr. Gyanendra.
So I would put it this way, that the surgery has 2 parts. One is debridement and another is sequestectomy. So it means you remove whatever is infected by the fungus, the infected soft tissue, sinus lining, mucosal tissue.
Where would you do that? Differentiate between 1 and 2.
I feel both of these are part of every surgery which we do.
Okay.
Because sequestrectomy inadvertently in a lot of patients, some part of the bone would be avascular. We need to define how much is avascular. As Dr. Aditya in previous slide, he showed that there was a lot of piece of maxilla was avascular. In initial early cases, only a few part, that is basal bone or bone related to only floor of the maxilla, they will be avascular. So we need to identify how much of bone is avascular, which does not bleed. That also should be removed at this time.
So the take-home message should be, you should remove all the avascular tissue and necrotic tissue as much you can do safely, and that should be your goal. How you do it.
Yes.
Yeah. So coming to Dr. Prashant, should you do a multiple debridements like I do it? I could not get it. Patient is sick. The anesthesia could not go on. I would go on for after 2 to 3 days. Again, take the patient up after the patient is on antifungals. Do you do multiple debridements in your 19 cases? How many of these cases went for multiple debridements?
So of
Dr. Prashant,
So of my 19 cases, I didn't go for a revision surgery because I could finish up everything in one setting. And most of my cases were early cases. None of them were extensive disease where I had to go for a repeat one. And so for the part of ensuring that whether it has gone into the orbit or not, so I get an MRI with contrast, check if there is involvement of the musculature. If at all there's any involvement of musculature, then I would go for a filtration.
For orbit MRI. Okay, Dr. Sumit, a quick answer. How many of the cases went for multiple debridements?
So out of the 34 cases which we have operated, the crux lies in early diagnosis. So you have to ensure that most of these cases are, picked up early. And like Dr. Prashant said, I agree, middle turbinate is the culprit, which you find a change in the hue in the color as you compare to the other side of the turbinate. Now, out of the 34 cases, only 3 patients underwent debridement twice because the disease spread from the nose and paranasal sinuses to the maxilla area to the alveolar process. Now, one more important thing, that all these patients which you plan for debridement, the disease is in a way that the tissue is avascular, and you have to remove the mucosa which is not looking good, the bone which is dead. And MRI with gadolinium enhanced is imperative because sometimes you have disease lying in the infratemporal and the pterygopalatine fossa, which you will not see on a CT scan.
Okay.
And if the disease is left behind, the drug is not going to act. The amphotericin is not going to act. One more thing, the country has faced a lot of shortage of amphotericin B, especially liposomal. In such settings, the disease control has not been 100% by the surgical debridement because the patient should receive a continuous supply of liposomal.
We'll do that. So basically the take home for surgery would be, surgery is the best way to how we can cure more patients, and that is the way. You should debride all the necrosed tissue and the devascular tissue. More than one is also fine. But the objective is to debride it. That's the point that is done.
One more point.
If you look at the pulmonary mucormycosis.
One more point, Dr. Sahoo, just one more point. 3 of the patient out of 34, we did not find any disease in the nose, but it was entirely limited to the infraorbital rim at the level of the infraorbital nerve and vessels in the maxillary sinus going to the zygoma. So that is very important. Like the study said, 48% you mentioned had maxillary sinus disease. So we also saw in patients where there was nothing in the nasal cavity. It was only isolated to maxillary, especially the infraorbital rim area.
Okay, so that is it. I can quote a paper. If you are not operating, those patients have a near total 70 to 80% mortality. So surgery has to be there. Then only your drugs can reach, and that has shown to improve the survival. So now coming to Dr. Rajiv. Sorry, I could not involve you more. But can you tell me which amphoby, and can we use conventional amphoby? And if you use conventional amphoby at the dose prescribed, can you go beyond 4 or 5 days, maybe 1 week, max 10 days? What is your take on that?
Well, when you use the liposomal amphoby, I've used it for
conventional.
Conventional amphoby, after 5 to 6 days, you are going to face a lot of rise in the creatinine. It is going to become very difficult task. So either the patient makes it or ends up with lots of other electrolyte as well as electrolytes we can manage, but creat goes up, it becomes very difficult. But like someone said, it's better to have a patient with a kidney failure rather than a dead patient.
No, I would not. I disagree with that statement in total. Each organ is important. I feel that is not the way I would see it, but there's a fair view on that. So, Dr. Pavan, if I have the 3 drugs, posaconazole, and I have a scarcity of liposomal ampho-B, first, can you tell me, is any dose below 5 recommended for mucomicrosis, or it should be a baseline 5 milligrams per kg?
So previously we used to use the low dose and increase it gradually, but in mucormycosis, definitely we need to start with 5 milligram per kg per day of a dose. So definitely no.
Okay, so point number 1 that's taken, that the dose in mucor has to be 5 milligrams. In CNS, you might go up to 10 milligrams per kg also. Point number 2, would you use a posaconazole, prefer posaconazole if it's available versus the conventional ampho?
Actually, I lost the voice.
You are there?
So can you repeat the question for me?
Yeah, would you use a posaconazole versus the conventional ampho-B? Which is your preferred? All of us know liposomal is the preferred. Am I clear? Dr. Govind, can you take that if I have some issue with him?
Yes, sir. Tell me now.
Yeah. So,
sorry.
If there is liposomal amphotericin, then that's it, because it's easiest to work with.
That's it then.
Posaconazole IV loading followed by prophylaxis, treatment IV or oral with gastric resistant tablet is not a bad alternative, because it covers mucoria better than most others do. And in that scenario, when posaconazole is also not available, and if you have money, you can use isobuconazole. Prisamba is an excellent drug.
Yeah. So basically it comes down to that it will be liposomal ampho-B, and it will be anything beyond 5 milligrams is what dose we are looking at. Dr. Roshni has a question, and if you can take it, for how long should we be doing, Dr. Pavan, now if you can hear me, for how long should we be using ampho-B post-surgery, mucormycosis per se, how long you should be using antifungal? Let's put it that way.
Hello.
Are you there? Yeah, are you there?
I'm there, so somehow there's some network. Can you repeat this question for me?
How long should you use antifungal post mucormycosis surgery or debridement?
So the intensive treatment with amphotericin is recommended for 3 to 6 weeks if you have the drug available, and change over to posaconazole versus voriconazole. The duration of treatment ranges up to 6 months. It depends on the clinical improvement, the radiological improvement. When you document there is histopathology, you do not have evidence of a mucor. These are 3-4 criteria we look at to decide whether we can stop the treatment. So definitely clinical, radiological, and if at all histopathology possible.
No, Dr. Roshni, I think you got it. The panel tells you that the liposomal, which is a very costly drug, at the dose prescribed is minimum 5 milligram per kg is the preferred. You go on for 3 to 6 weeks, look at the radiological response probably. Then you can go, you have to, after the acute phase is over, you go to posaconazole, or some people have told that you can go to isavuconazole, which is a costly drug, but has been actually having a good evidence. Patients who are refractory, have not responded to ampho-B, actually isavuconazole is a better drug, although posaconazole has been tried. And the duration rightly pointed out has been that you look at radiology. In the radiology, there could be a scarring, but if that is there and patient has been controlled, and most important is the immunocompetent factor has to be coming back. You do not stop this antifungal till the patient is immunocompromised. If you do that, the mucor is going to come back. That's what the literature is. Move on, please. I think we have covered the duration. So last, I will give it to Dr. Bhavesh and the colleague, Dr. Sanjay Gandhi, who is from Shalby Hospital, and they can take it for the next 3 slides and they can use that data. Dr. Hemant Malhotra has put up, can we use 10 milligram per kg? Sir, in the CNS disease, they prescribed, they can use it in the data which has been published as the guidelines for international group for mucomicrosis pre-COVID also. They used 5 to 10 milligrams. They have also escalated to 10 milligrams. I think that has answered your question, sir.
I think medical oncologists would very, very rarely have used 10 milligrams per kg.
So we use 2 to 3 milligrams. That's what, because we have mainly used with aspergillus. We have mainly dealt with aspergillus. And when we go to mucor, actually the starting dose, sir, has been a 5 milligram per kg, sir. That's the sorry part of it. Okay. Can Dr. Bhavesh or Dr. Sanjay or Dr. Dharmesh, if is there, take up this next slide. Next slide, please.
Can organizers present my slide?
Yeah. Yeah, it's already there.
Already over to
Bhavesh bhai galti kar hi nahi sakta ki aapka slide na dal.
Over to Sanjay.
Yes,
please, someone take it fast.
Yes.
Yeah. In last 1 month, we have around 192 cases. Majority were from the maxillary sinus, nasal cavity, and some of them from palate biopsy. I have received 14 specimen of eyeball. 3 cases were skin biopsy from the scalp. 2 cases were from jejunum, and they presented with diverticulitis. Out of, I have received 6 diverticulitis cases in COVID positive patient. 2 were showing mucormycosis. 1 penile amputation specimen was showing mucormycosis, and 1 in bladder biopsy. Around 29 cases presented with multiple site involvement. And if you see, other data are similar to what we have discussed: age presentation, male to female ratio, and other part.
Next slide, please. Next slide, please. So this is the data, and this is the last data, as good as Dr. Aditya's data, and the series is as big as Dr. Aditya. Next, please. Dr. Roshni has put out posaconazole. It's a very expensive drug. Dr. Roshni is sorry. All the drugs that we use, even liposomal, at that dose prescribed, will be much more costly than posaconazole probably. Next slide, please. Next. Caspofungin, we told it has not much of a role. All the people have used it. The only thing I can speak is there are people have spoken about combining amphoby along with one of the azoles. That has been done, and people have done it. Caspofungin also, the trial is there. Next. We'll skip this. Just go to the last part. Next. Yeah. So I have this last slide, last question, and I would like this, and then I will ask Dr. Hemant to just brief it up if that is the right approach, because he has a good experience in the prophylaxis. Dr. Rajiv and Dr. Govind, we all know that prophylaxis works in the high-risk oncology patients, hemato-oncology patients. So do you feel we have saved a lot of patients from possible mucomycosis? Is it the appropriate time if ever a third wave happens? Because this wave is gone. The patients who are high risk, diabetes, uncontrolled, when they come into hospital, we should be giving them prophylactic posaconazole. Dr. Rajiv first, and Dr. Govind, and then Dr. Hemant can tell what he feels about it. Dr. Rajiv, you're there? Dr. Govind, can you take that?
Yeah. No, I don't think blanket empirical antifungals will be the right message, because we don't even do that in others. But yes, we must be able to differentiate a mild, moderate, and a severe, and a cytokine storm, and a COVID HLH. If everything is COVID and everything is being treated on the exact same lines, because half the junk we're writing, doxy, ivermectin, limsi, azithromycin, it doesn't have any data, but we are all using it, and most centers are being used without any data in the treatment now. Having said that, if a patient who has a high candida score, by owing to virtue of critical care mechanics, should be given fluco, because you've got so many tubes on. You need to bring down candidiasis down. Only when candidiasis gets, you go to the other end of the spectrum, you've already lost the battle with candidiasis there. 2, higher patients who are on immunosuppressive therapy like baricitinib, tofactinib, tocilizumab, not bevacizumab, it doesn't produce immunosuppression.
Agreed.
These definitely. Now, my real scourge with what is happening is that people don't take 6 milligram dexamethasone very seriously. They think solumedrol is better. For what reason that is, I am not able to find enough data. There is some anecdotal data where solumedrol goes into the alveoli a little better.
Yeah, it works better in lung. That's what the respiratory.
Yeah, but that is not conclusive. That is not conclusive across our sections at all. Now, having said that, if you don't believe 6 milligram dexamethasone, and just to keep the ampule going, you give 8 milligrams of dexamethasone, it is equal to 60 milligram of methylpred. Nobody is giving 60 milligrams in a day. People are starting with 125 load and 40 TID, or maybe 60 TID. There are instances where I'm seeing pulse dose of 750 B. Now, these are the patients where if you think this is entitled, if you're going more than 10 days of 6 mg dexa or equivalent or higher, if he's pre-existingly a diabetic or a diabetic owing to what you have done, then definitely he requires some prophylaxis, definitely for candida, And if you can think that this patient is immunosuppressed enough, is going to be ventilated, is going to be here for a long period of time. In those patients, I think POSA long-acting hepatotoxicity is not a problem. Could be, but in the ambit of looking at hepatotoxicity.
Agreed. No reports have ever told that. That was a thought that exactly quote that there's a high risk patient. You have to choose that patient who probably can. Prophylaxis, can it be done? No one knows it. But because we have seen that happening in the hemato-oncology section, can we replicate that thing? I do not know. Dr. Hemant sir, last word. Is it the right time to really choose the very high risk which Dr. Govind told, and those because we are losing lives to mucor? Or should we wait for further data? I don't know where the data is going to come.
So, DP, do you mean this Hemant, me, or do you have another Hemant?
Sir, sir, you have the authority. It has to be you, sir.
Okay, thanks a lot. So, my feeling is that for this particular issue, prevention is better than cure, and we are rampantly using steroids. Private practitioners and physicians, as soon as you have a throat swab positivity, whatever kind of disease you have a photocopied prescription, 2 antibiotics, 1 oral antiviral, 1 steroid, 1 zinc, 3 multivitamins, 1 vitamin C. I've seen tens of prescriptions like this. So somehow has to be discouraged. And I think that to my mind is the most important thing. High index of suspicion has to be maintained for diagnosis, catch it very quickly, do a debridement surgery if needed, give adequate duration of antifungals, but try and prevent it and diagnose it early.
Thank you, sir. And next slide, please. My last slide. Conclusions. And I think Dr. Hemant Malhotra, I did not share slides with him. So he told a lot of things what I thought of. Mucomycosis is a rare but potentially lethal complication during this COVID time. That has come up to us. Next. Diagnose is essential, but more important is to have a high degree of suspicion. That's what Sir echoed. And that's what I feel. And a lot of my panelists told, as Dr. Sumit told, cases are coming early. Dr. Ganandra told, patients are coming early. Debridement followed by antifungals. You cannot let the surgeons out of your team, the ENT guys, the maxillofacial have to come in. But the radiology is so important. When you think of an infraorbital or orbital, MRI comes into picture, be liberal with your radiology. Diabetes, uncontrolled sugar, COVID, and probably hypoxia. If I can use the indiscriminate use of medications, let it be steroids and antibiotics, could be the 4 or 5 edges to the etiology why we are facing this epidemic within the pandemic. So with that, I really thank all of you, and I thank Dr. Purvesh sir and Amish sir to allowing me to go beyond my scheduled time. Thank you, sir. Back to you.
Thank you.
Thank you very much, Dr. Sahoo. Thank you very much, Dr. Aditya. Thank you very much for all the panelists who have, shared their experience and personal information and data. Thank you, Dr. Hemant, for chipping in, even though you were not part of the panel discussion. Can you go to the previous slide? I just want to end. Next one. Somebody has stopped the slides. Can I see my last slide, please? Yeah. So I would like to end by inviting everybody back on 8th June, which is next coming Tuesday. At that time, we have 2 important topics. One is COVID and cancer surgery, which is going to be moderated by Dr. Somashekhar from Bangalore. And the other one is low-dose radiotherapy for COVID treatment. In the meantime, I hope that all of you remain safe and sound. And please take care of yourselves and your family while you are frontline warriors looking after the COVID patients. Thank you and good night.